Good afternoon, everyone. Thank you so much for joining us today, our third and final training webinar in our three-part webinar series for the 2018 Cost Analysis Rate Setting Project. I would ask as a courtesy for you all to mute your lines so that there's no background noise. This is a recorded webinar. If you have questions, we'll definitely have time for question and answer at the end of our session. And at that point, you can unmute your line if you'd like. You're also welcome to use the chat box. But if you would be so courteous as to mute your line, I would greatly appreciate it. Excellent. So part 3 is essentially putting everything that we've learned together to develop your fee schedules and have a good understanding of how to use this information to negotiate with health plans. As a reminder, our webinars are all recorded and they are located on the rtwelter.com/public health page. I've gotten a few emails requesting the PDF files for the webinars and the slide decks, and we will actually be posting those on our website in the same section. So those will be coming very soon. Jody is on the line and available in case you guys need anything. I know a lot of you are at the NEFRA conference. I hope that you're having a great conference. When you go to our rtwelter.com page, you'll want to click on the coding tab and then go down to the public health tab. And then if you'll scroll down that page, you'll see the billing and coding manual, resource guide, and then there's a tab for webinars. That's where all the recorded webinars are. And like I said, we'll be posting the PDF files of the slide decks for you as well. We're going to briefly recap on some of the things that we covered in webinars 1 and 2. I encourage you to reference those webinars if you missed them on our website. We're also going to discuss how to develop your fee schedule based on the costs that are identified through the Cost Analysis Rate Setting Project, and how to use that information to negotiate with health plans. We also have some really nice tips with regards to how to manage the contract negotiation stage once you get to that point. Todd Welter, that's what he does every single day. He is a guru when it comes to contract negotiations. So if you ever have any questions about contract negotiations or contracts that you are currently in the process of negotiating with payers, please feel free to reach out to us. Him specifically, he's amazing when it comes to contract negotiations. Performing a cost analysis is a Colorado Title X requirement to demonstrate how sliding fee scales are developed. As the OPA states, charges must be based on a cost analysis of all services provided by the project. These trainings are designed to assist family planning programs in assessing the cost of providing clinical services. This allows programs to set appropriate fees to recover the reasonable cost of the services they provide. This information is also very useful in the negotiations with third-party payers regarding appropriate reimbursement for services. Every successful business knows the importance of understanding all the costs involved with providing a service. Family planning programs are offering services in an era of escalating costs and shrinking federal and state support, as well as increased competition. To remain viable, it is essential for family planning programs to implement strong business practices, and this includes the collection and analysis of financial information that will provide insight to the real and complete costs of doing business. Only agencies with a sound financial management plan and a complete knowledge of the cost of doing business will remain financially viable. This becomes increasingly important as the United States continues to implement healthcare reform as well as payment reform. So our cost analysis is going to allow us to make informed decisions about setting our fees, understanding the costs associated with our services, negotiating payment and rates, as well as sustainability. To recap, we talked about in our first webinar identifying any and all costs related to family planning in Title X. So really looking at that on a very granular level, and then taking those costs and categorizing them into defined cost categories, such as operating expenses, personal expenses, provider-specific expenses. We talked about all of those different options for your cost categories. And also separating expenses by program so that we're only accounting for the costs associated with family planning in Title X. This is going to look very different for each of you depending on the structure of your organization and the programs that you have. You are free to use estimates based on calculations that you're using when you're evaluating multiple agencies and programs within an agency, as well as time studies with regards to employees and percentage of employee time devoted to family planning in Title X. We review the budget spreadsheet that helps really give you a real life picture of what this looks like when you break down each of your cost categories. And we looked at an example of a 2-nurse practitioner family planning provider setup where the expenses were split down the middle because both of the nurse practitioners are full-time family planning. This template will be distributed to you later in the month by Jody. She'll be sending these out to everybody. You are not obligated to utilize this. You can use whatever method works for you as far as your cost analysis and cost setting, so long as you can explain the rationale. We also discussed identifying your family planning specific CPT codes. If you have a robust electronic health record and practice management system, this data is fairly easy to retrieve. We have our list of CPT codes specific to family planning. As you guys know, this is not an all-inclusive list. And then we discussed utilizing the RBRVS or non-facility RVU as a means for calculating costs, as well as the Medicare Fee Schedule. And then we also discussed in our webinar 2 how to take this information a step further and really look at the calculations based on volume. So taking our family planning CPT codes, looking at our reimbursement for Medicare, and also accounting for our non-facility RVUs, looking at our total volume for these procedures in a given time period, and then equating dollar figures as well as RVUs to those procedures so that we can get an idea of expected revenue from those codes. We talked about RBRVS and the components of RBRVS and how payments are calculated. Payment is calculated based on relative value, GPCI, and then the conversion factor, which is a number that's set every year. Commercial health plans typically use a fixed fee schedule based on Medicare. It's very common with commercial contracts to get rates such as we're going to pay 120% of the Medicare fee schedule. That's very typical as far as the language they use in the contracts for your fee schedule. The RBRVS is updated annually to reflect new and revised CPT codes, as well as changes in the RBRVS. The Medicare fee schedule, we discussed how that is a best practice for cost analysis, cost setting. This fee schedule encompasses a complete list of the maximum fees used by Medicare to reimburse providers and suppliers on a fee-for-service model. CMS develops fee schedules annually for every different type of provider, whether you're a medical equipment supplier, clinical lab, physician. They have fee schedules for all different types of providers and services. These are also updated annually to reflect new CPT codes and changes in reimbursement. To obtain this information, you'll want to go to the cms.gov website and take a look at the physician fee schedules. There are a lot of download attachments, so just make sure that you're pulling the correct one that applies for your services. We also talked about volume and really how to define value based on the volume that you provide from the service standpoint. I'm going to ask you guys one more time if you wouldn't mind muting your lines so that we can alleviate any background noise for our folks that listen back on the recorded line. I'm showing that everybody's muted except for Cynthia Horn. So Cynthia, if you're there, if you wouldn't mind muting your line, we would greatly appreciate it. Thank you guys so much. So volume, really to define our value. So we've got our list of CPT codes, we've got our non-facility RVUs, our Medicare fee schedule reimbursement, and then we're looking at our same example of the 2 nurse practitioners with the full-time family planning 50-50 distribution. And we're looking at our volume based on a week's time. So if we looked at 99203, which is a new patient, level 3 visit, very common service that you guys probably bill every single day, we're looking at 7 encounters per week for nurse practitioner 1, 7 encounters per week for nurse practitioner 2, total of 14. And we're going to guesstimate an average monthly volume of 49 encounters. So we actually take that number, we multiply it by our Medicare fee schedule, and that gives us our estimated monthly collected revenue for 99203. So the really nice thing about excuse me, this process is that it gives you financial insight as to how your services stack up as far as revenue and what you're aiming for with regards to cash collections when you look at your costs. The goal is to cover your expenses, but I also want to mention that I know that this is a cultural shift for you guys. There is nothing wrong from a business standpoint with making a profit. And, you know, I'm not encouraging anybody to do anything illegal or anything, you know, unethical, but at the end of the day, a business is a business, and it's not a bad thing to be a profitable business. So this volume really helps communicate to the payers the value, the incredible value that you guys bring to so many people. It's incredible how Colorado has been a model for the country for teen pregnancy rates and all of the amazing initiatives that you guys have done. And you've really seen so much success as a result of your hard work and dedication. So this is a really exciting stuff for us because, again, this is leverage when you're negotiating your contracts. We also talked about the JSI focused cost analysis model and the materials and resources that are available if you should choose to use this model. The JSI model is great. It's very detailed, lots of bells and whistles. Maybe that isn't the best model for you, and that's totally okay. You guys are free and flexible to use whatever model works for your agency, your setting, so long as you can provide rationale on how you came up with your cost analysis. So we looked at the cost report that's provided by JSI, cost pool calculation, procedures to RVU conversion, which is very similar to the spreadsheets that we looked at for the volume and the value, as well as the utilization data report, which really drills into, okay, how much and how many times did we provide a service during a given period of time. So how do we use this information once we've broken down our costs and categorized them into cost categories and really dived into our volume and our realistic picture of what revenue looks like from a volume standpoint? What do we do with this information? We take this information and we use it to negotiate with our payers. And you can share your findings. That's also an option. You're not required to do so. You know, sometimes with negotiating, less is more, but you do have that data behind you, that thoughtful, very robust data that you guys have worked so hard to collect through this process is going to allow you to be very informed when you go to the negotiating table with payers. Also allows you to develop your fee schedules, your sliding fee scale, and do so in an informed manner. You're using the information that you've gathered to make these informed decisions. Analyzing productivity of your providers. That may not be something that you guys do a ton of, but you can really hone in, okay, how much is this provider producing versus, you know, some of your other providers? And then adjusting your staffing and resources based on that productivity and volume. If you have a very small volume, it may not make a whole lot of sense to have as many providers dedicated to that particular service line. So identifying costs and reimbursement associated with costs and the cost of doing business allows you to make very informed decisions about all of these things. Excuse me, guys. I have been a little under the weather, and everybody that has had the crud this year knows that the cough sticks around forever. So I apologize for that. When you are developing your fee schedule, you'll want to make sure that you, again, understand the costs associated with doing business. So once you conduct the cost analysis and understand your costs, you can then take that information to develop your fee schedule. Sometimes we also call that a charge master. It's up to you on what you would like to call it. It is also your decision as to how you decide to structure or calculate the rates associated with your fee schedule. You just need to be able to explain how you came up with those numbers. You'll want to set your fees based on your expectations of what you want to be paid. And you have to be realistic about payment, but also what you choose to charge for the services you're providing. We're going to get into a sample fee schedule in just a minute to give you a better idea of how this looks from a real-world standpoint. When negotiating with commercial health plans like United Healthcare or Anthem, the Medicare fee schedule should always be your bottom line. You should never take less than what the Medicare fee schedule reimburses. And that's just a general principle when you are negotiating contracts. Medicare fee schedule is the bottom. Sample fee schedule. So column 1 are our CPT codes, which we've looked at several examples. So we've got 99203, which is a new patient visit. And these are very hypothetical numbers. You guys don't feel obligated to use these numbers. These are hypotheticals. and purely for training examples. Medicare fee schedule for a 99203 is $108.19. If you were to develop your fee schedule based on Medicare fee schedule and doing 150% of the Medicare fee schedule, that would enable you to bill $162 to insurance for a 99203. Keep in mind, what you bill is not what you get paid. You do not want to use the exact figure that you're going to get for billing. You always want to bill higher than what you're going to be reimbursed, and that's just a best practice. So 150% of Medicare would allow you to set your clinic charge master or clinic fee schedule to $162. Let's say, hypothetically speaking, your negotiation comes back and they are proposing 110% of Medicare, which is quite a bit different than 150%, which was, again, a proposed amount. If you were to get 110% of Medicare fee schedule, that would be $119 for reimbursement for a 99203. In negotiating, you always have to be able to give something to get something. So this number that you start out with should be high. It should be. You want to go higher because you always want to get more than what you expected. So 150% is high, but that's a good starting point at the negotiating table. It gives us room to negotiate. It gives us room for concessions. So if we went back to the payer and we said, nope, we're not going to take 110%, but we would be willing to take 120% of Medicare. That's fair. We would be looking at $130 for reimbursement for a 99203. So this gives you dollar for dollar value from a percentage of Medicare fee schedule on contract negotiation and how to really look at developing your fee schedule. The thing about negotiating with health plans is that they really communicate, again, based on Medicare fee schedule. So when you're looking at the Medicare fee schedule, you're essentially on the same wavelength as the payer. And keep in mind, your rates are going to be contingent on the area. So if you're in a non-metro area, your reimbursement will be higher than if you were in a metro area. It's all about supply and demand. So the less competition there is, the more leverage you have to ask for more. The more competition there is, again, based on the area that you're in, the lower the rate you will be able to negotiate. 110%, 120% of Medicare is very common and very realistic from a financial standpoint for developing your fee schedule. So supply and demand. 99213, also a very common service that you guys provide. If we looked at Medicare fee schedule, they will reimburse $72.81. So using that same principle, if we were to ask for 150% of Medicare, that would mean we would want to bill out from our fee schedule $109. We go to the health plan, we say we want 150% of Medicare. They come back, same thing, 110%, which is $80. We say, no, we want 120%, that's where we're comfortable. Then we would be looking at $88 for a 99213 as far as reimbursement. You are not obligated to utilize the Medicare fee schedule, but again, this is what payers are used to operating on, and it's also a very, very simple way to set your fee schedule. Your sliding fee scale must contain sufficient proportional increments so that the inability to pay is not a barrier to services. You guys understand that there should not be any barriers to family planning and Title X services. So keep in mind there should be sufficient increments for your sliding fee scale. This must be developed using your cost analysis for all services that you provide that are exclusive to family planning and Title X, and these would include clinical, lab, any supplies. Charges should be reasonable, fair, and equitable for all clients. And your sliding fee scale must be designed to cover the reasonable cost of providing each service. And, you know, I've repeated the OPA quote several times, and I'll say it again, they have to be based on a reasonable cost of providing the service. So you want to make sure that you are at least breaking even. You are covering the cost of providing the service with your fee schedule and your sliding fee scale. Sliding fee scale is required for Title X family planning. You guys know that. All Title X family planning services must slide to 0 for clients 100% the federal poverty level or below. This is a requirement. So keep this in mind when you are developing the fee schedule. Must include a schedule of discounts for low to moderate income clients, and that's going to go back to your brackets. And it must be updated annually to incorporate the most recent federal poverty level guidelines. So these change annually, and you'll want to make sure that your sliding fee scale reflects those changes. This is a sample sliding fee scale on a 5-code model, and we're basically looking at federal poverty level, as you guys know, 100%, 0% of the reasonable cost. So everything is slided. The patient does not have any cost share. And then we look at our other brackets, pretty self-explanatory. You guys are used to this. You know this in and out, FPL level, and then the cost share for that particular client. So how do we take this information and negotiate specifically with commercial payers? There are many commercial payers. Here are a list of some. This is not all. So you could potentially have multiple contracts with commercial payers depending on who you decide to contract with. And a lot of that is going to be contingent on your area, your patient population, and the demographic of your patient population. This breakdown is public information. You can access this, and it's essentially a carriers with approved plans, and this was ACA from 2015, and we're looking at, it looks like 20 carriers, again, not all inclusive, and we have our number of plans offered on the exchange as well as off the exchange. So we're looking at real numbers for the amount of plans that are offered by different insurance companies, both on exchange and off exchange. The point of this slide is just to let you know that there are lots of commercial payers, and you'll want to figure out which ones you would like to target for contracts. And this is publicly available information. Some questions to ask when you are approaching the negotiating process. Do you need the health plans to direct volume to you? If you do, that's fine. Typically how it works is if you are asking health plans to direct volume to you, they are going to ask for a discount. So it's essentially a discount for volume model. Maybe you don't need health plans to direct volume to you. Maybe you already have that volume established. That's great. It gives you negotiating power and leverage when it comes to the contracting process. So 2 things to consider. Do you need volume directed to you? And if you don't, make sure that you're stating that in your negotiations. And then, can the health plan direct volume to you? So you may not need it, but you can offer the option of allowing them to direct volume to you. Some tips for negotiating reimbursement. As I said in our example for our sample fee schedule, start high. Start at 150%. You don't know what's going on from the payer standpoint. Maybe you have more leverage than you think. And payers will always ask you, what do you want? What is it that you're after? So start high with the intention of negotiating and really think about what your bottom line is as far as what you're willing to take. Again, based on the informed decisions of your costs and the costs associated with doing business. So you're having all of that knowledge in your arsenal so that you can go to the health plans and say, hey, we deserve a high rate because we have, X amount of volume and all of the other things that you've identified in your cost analysis project. Share that the plan is reimbursing lower than other plans based on your fee schedule analysis. So you never want to name drop, but you can, as a negotiating tactic, tell a payer or a plan, you guys are offering me less than, some of my other contracts. You guys are the lowest. So you can use that to get them to come up on their rate. It doesn't always work, but it's a really good negotiating tactic. You don't want to name drop, you don't want to share who's paying what, but you can flat out tell a plan or a payer, you are offering me the lowest that there is. I'm, getting X amount from 3 other payers. Can you come up? Prepare to wait, and then wait some more. Todd does this every day, like I said earlier, and his statement was that it takes anywhere from 3 to 6 months, usually, for a contract and the contract negotiation process to conclude. It can take up to a year. For you guys, because you are different than the majority of other providers that are approaching this process, your contracts are typically less complicated. So 3 to 6 months is average waiting time for contract negotiation. Prepare to negotiate. As I said before, know your strengths. Understand what you have to bring to the table and use that as leverage and negotiating power. Some things that you can utilize for negotiating are the fact that you guys are low-cost providers. You are saving the health plan money because you offer services at a lower cost than some of the other organizations and practices. You're also taking care of a very underserved population. There are many barriers and factors that go into the populations that you treat. So these are some things that you can use as talking points when you're negotiating health plans. At the end of the day, if you're not satisfied with the final offer, you can always discontinue that contract or the contracting process. So if you're not happy with it, you don't have to move forward with it. You're not obligated to do so. Some stipulations in your contract that will be specific to providers are going to be things like office hours, if you offer any after-hours care, timely filing submission, which are the time limits that you have to submit claims for proper reimbursement. Claim submission, non-discrimination, policies regarding medical records and safeguarding PHI, policy manuals, a published provider directory, and if your patients are on a commercial insurance and they have a cost share or copay, it is your obligation to collect that. Terms and termination. Most of the time, typical contracts are multi-year, so 1 to 2 year contracts. Termination without cause, there should always be a way out in your contract, and it should be explicitly stated. How can you get out of the contract if you are not happy? Some other general provisions, reciprocity. It's a two-way street. Everybody's accountable for what they do. If you guys make a mistake, it's on you. If the plan or the payer makes a mistake, it's on them. There's also an amendment process so that you're not stuck in a contract, and you want to really make sure that you're paying attention to the details of the entire contract, because payers are notorious for sending things that may or may not make sense, and it's your job and responsibility to really look at every single line item of that contract to make sure that you agree with it. Indemnification, as well as legal proceedings, in case there were any kind of arbitration or need for legal. Some unacceptable provisions, so things that would not be acceptable in a contract. Restricted access to fee schedules. Fee schedule that applies to non-covered services, so things that the health plan would not cover. Lack of clarification regarding entities with access to contract and discounts. This is very, very technical language, but it's important that you guys understand what to look for in a contract. Payer prohibits provider from establishing panel limits and practice parameters. Any reference to most favored nation. Non-standard coding, billing, or claim submissions processes or requirements. Cumbersome or manual referral or prior authorization process. Timely filing less than 90 days. And health plan able to amend contract without your signature. These are things that are completely unacceptable, and if you see them in your contract, it should be a red flag. Keep in mind, contracting and credentialing are ongoing processes, and you must stay active and engaged in these processes constantly. They are ongoing. It's also very important that you review your contracts and fee schedules at least every 2 to 3 years. So the great thing about this project with CDPHE is that it really holds you accountable to being engaged in the contracting and credentialing process, because you're already required to do so with the cost setting and cost analysis. So that is one great thing about this whole activity. So we really went from A to Z on what this process entails as far as how to conduct a cost analysis. You're allocating all expenses to the appropriate cost categories and looking at your relative values for the services that family planning provides, the utilization, analyzing how much volume for each individual family planning service, and then determining the costs of each service and establishing fees based on all of this information. So it might sound like it's very complicated, very long, drawn-out process. But if you follow these steps and the tools and the resources that we've provided, it doesn't have to be a very time-intensive process. Some helpful reminders. You may use any form of cost setting that is appropriate for your setting, so long as it can demonstrate how fees are determined on your sliding fee scale. So that is wonderful news. You have complete flexibility with whatever method you choose to utilize for cost setting. If your organization has recently updated its cost setting activity, it must have been completed in the last 12 months. So our cutoff is April of 2017. CDPHE, as well as RT Welter, are both here to help you. Your contact for any cost setting, cost analysis questions at CDPHE is Jody Camp, and her email and office line is on this slide. Please utilize her. She is wonderful and more than happy to help you guys with whatever you need. Our timeline, so this is the final webinar in our web-based training series. So next Monday, no webinar. Cost setting template, your budget template will be distributed. That's the template that itemizes all of your cost categories and expenses. You are not required to use this form. You can use any form that works for you. And then the cost setting summary uniform template is a mandatory form. It is not optional, and it must be used. And we'll talk about that information in just a second. Our sample budget template. Again, this is the template that will be emailed to you by Jody. You're not required to use it. It's purely an option. Our cost setting summary uniform template. So this is the mandatory form that has to be submitted with your cost analysis and cost setting. And it's essentially explaining and providing supporting documentation as to how you carried out your cost analysis. So how did you do it, and particularly who did it? Did you engage a third party, and if so, who? Was it performed internally by your accounting department or some other family planning staff or an other entity? And what period of your organization's financial data did you use? Did you use a calendar year, a fiscal year? Which reporting period did you use to base your cost analysis? Calendar, fiscal, or both? You'll need to provide supporting documentation of the itemized expenses included in your cost analysis and the annual cost for each item. The thing that's going to probably take you the most time is digging up these extra pieces of supporting documentation. How did you determine the value of your services? Did you utilize Medicare Fee Schedule? Did you utilize RBRVS, or did you utilize some other method? And I will remind you once again, you are free and flexible to use any method so long as you can provide your rationale. Supporting documentation with a list of CPT codes and determining the annual volume for each, so your volume report by CPT. Supporting documentation for your most recently approved sliding fee scale. And then if your organization did not use the methods reviewed in our training series, you'll need to describe the method your organization used. And then any comments or additional information that would be needed to validate your cost analysis process for 2018. Next month, April, it's not that far away, guys. Cost setting, cost analysis process should be underway. You guys should really be in the thick of this. You have the option to contact RT Welter for technical assistance. We are more than happy to provide any consultation or coaching regarding how to perform your cost setting or cost analysis activity. We cannot do your cost analysis for you. You are required to do that for your agency. But we're more than happy to help or guide you in any way that we can. So we have partnered with CDPHE and we'll provide 30-minute phone consultations and coaching sessions. You must submit your cost analysis to CDPHE by May 1st. I'm going to encourage you guys, please do not wait until the last minute to do this. You will be very sorry that you did. Start on it now and work on it a little bit each week so that you can be well prepared for this deadline. It is a hard deadline that cannot be changed. Technical assistance contacts, you can contact myself or Todd Welter, and our email addresses are provided as well as our office lines. You will get a much quicker response via email, but either option is available to you. If you would like to schedule a 30-minute phone consultation, feel free to reach out to us via email. May. Cost analysis is due by May 1st. There is no wiggle room with regards to that deadline date. RT Welter will be reviewing your cost analysis for every single organization and will be providing necessary feedback based on anything that's come up through our evaluation process. And we may need to contact you to get more information or ask questions. So we'll be doing this throughout the month of May. All cost-setting activities, including updating your sliding fee scale, must be completed, as well as giving time for editing and approval by May 31st. This is a contracted activity with OTA and Title 10, and it must be completed this fiscal year. Unfortunately, there is no wiggle room with regards to these deadlines. So get them in your calendars and really think about how to plan accordingly so that you can get this done. At this time, I would be happy to take any questions that you guys have. And you're free to unmute your line at this time. Thank you, Jody. I really appreciate you guys, and I hope that you're having an awesome conference.
Hi, everybody. This is Jody from Colorado Department of Public Health and Environment. I want to thank Tony. This third and final training has been really helpful, and I'm sorry you're not feeling well, but you did an awesome job getting through that, so thank you. For everybody on the phone call, I want you to know while Tony was speaking, I did send kind of the uniform reporting template, so that should be, if not in your inbox, certainly in the program coordinator's inbox. If you have any questions, feel free to reach out to me and I can send you a fresh version. In addition to that, as Tony explained, I sent a Excel spreadsheet that's just a helpful tool if you want to start kind of taking an inventory of not only what methods or what procedures, methods, and costs that you have in your clinic as it relates to family planning. This is not a required tool. It is just a helpful template that might help you on your way in terms of creating your cost analysis. So those two tools were emailed out. In addition to that, I sent a reminder about the 30-minute coaching and consultation. So thanks, everybody.
Thanks, Jody. Thank you so much. Any questions, guys? Anything that's come up as you're digesting this information or thinking about how to start? Feel free to ask. There are no dumb questions. All right, well, it doesn't look like there are any active questions. You can always email us or give us a call and reach out. I really appreciate everyone's time and attention, and if you are at the NEFRA conference, I hope you have a wonderful conference, and I will be ending this line, and I encourage you all to check out our website for any recordings or any content information that you would like to review. Thank you guys so much. Appreciate your time.